Hello and welcome to our new attendees and those who have been with us for past webinars. Thank you for joining us for today's Nova Biomedical webinar, Detection and Management of Acute Kidney Injury in the ICU. Our speaker today is Dr. Rolando Clare del Granado, Professor of Medicine at Universidad Mayor de San Simeon School of Medicine in Bolivia, and Director of the AKI CRRT program at Hospital Obrero in Cochabamba, Bolivia, also member-at-large of the International Society of Nephrology Executive Committee. Also presenting today is Dr. Dennis Begos, Medical Director from NOVA's Medical and Scientific Affairs Department. Dennis will join us to discuss point-of-care diagnostic options for identifying and managing AKI in the hospital. I'm Rick Rollins, Senior Marketing Manager at NOVA, and I'll be moderating today's event. Feel free to post questions during the webinar using the Q&A window on your webinar console. We'll have a brief Q&A session following the main presentations, and we'll follow up with a full list of questions and answers shortly after the webcast, including those questions that we may not be able to address in today's session. This webinar has been approved for 1 contact hour of PACE continuing education credit and 1 CERP unit by the American Association of Critical Care Nurses. For participants in these organizations, your CE certificate will be emailed to you once you complete a post-webinar survey. A link to this survey will be sent to you just after the webinar concludes. If you fail to receive our email, please be sure to check your junk mail folders in your email system. Please also take a minute to visit our website to register for future live events and to explore our on-demand content with topics ranging from clinical testing and cell culture to veterinary diagnostic testing. Be sure to subscribe to receive notices of future NOVA educational webinars. The NOVA website is also a great place to learn more about whole blood critical care testing products. And now on to our main presentation. Dr. Rolando Clare del Granado is head of the Division of Nephrology at Hospital Obrero No. 2 in Cochabamba, Bolivia, and past president of the Bolivian Society of Nephrology and Hypertension. He has been actively involved in the International Society of Nephrology and its initiatives, including the 0x25, the Kidney Care Network, and the development of the ISN COVID-19 Resources site. Dr. Clare del Granado's research interests include the epidemiology of AKI, extracorporeal therapies for AKI, study of biomarkers in AKI, mobile health, and the use of social media in education. He has contributed to more than 70 publications. Please welcome Dr. Rolando Clare del Granado.
Thank you, Rick, for the introduction. Hello, everyone. My name is Rolando Clare del Granado, and I'm an adult nephrologist working in Cochabamba, Bolivia. I am the head of the nephrology division at Hospital Obrero No. 2 in Cochabamba, Bolivia, and a professor of medicine of Universidad Mayor de San Simón in Cochabamba, Bolivia, with a research interest in AKI and critical care nephrology. Today, I'm going to talk about a practical approach for detection and management of AKI in the ICU. In the following 30 to 40 minutes, I'm going to discuss the following points. I'm going to show you why AKI is a silent killer globally. I'm going to show you 2 early detection modes of AKI or proposals for early detection of AKI that would be the nephrology rapid response team and the 0x25. Even though that the 0x25 was designed for community-acquired AKI, we have adapted to be used in the ICU setting. Then I will show you how to use fluid volume expansion, and I'm focused in 2 specific points: which solution you should use and the 4 phases of fluid therapy. Finally, I'm going to briefly discuss if you should use or not diuretics, and I'm going to end discussing timing of renal replacement therapy in patients with AKI. Well, we need to raise awareness of AKI since it's a silent killer globally. These are data from US, and it shows the adverse outcomes that AKI has. Annually, 300,000 people die in the US from AKI. Once you get AKI or you develop AKI in the hospital, the cost per admission exceeds the total hospital cost by a mean cost of $7,500. That means that the cost that each year US has to deal with AKI is around $9 billion. Also, your length of hospital stay will increase, on average 3.5 days. The odds of death associated with AKI increases as you develop a higher AKI stage. For example, if you develop AKI stage 1, your odds of death could be 5%. However, if you develop AKI stage 2 to 3, your odds of death could be as high as 55%. And also, the death rate year of AKI is higher than diabetes, heart failure, breast cancer, and prostate cancer combined. But this is not only a problem in the short term. Also, AKI has long-term adverse outcomes. This is data from the same study, and I'm showing you here data from low and low-middle income countries. Annually, we have 11.3 million cases of de novo AKI or AKI over CKD. This means that each year, 10 to 50% who develop people who develop AKI will die. By 24 months, of the 10 million who survive the first episode of AKI will develop end-stage kidney disease. And by 3 years, from the 9 million people who survived the first episode of AKI and did not develop end-stage kidney disease, those people will progress to chronic kidney disease stage 4 or will develop chronic kidney disease stage 4, that increasing the burden of chronic kidney disease to healthcare systems around the world. Having this in mind, the International Society of Nephrology developed the 0 by 25 initiative for acute kidney injury. That means they want to achieve 0 preventable deaths caused by AKI by 2025. This study and this initiative was focused on low and low-middle income countries in 3 regions: Asia, Africa, and Latin America. One of the first things that was proposed by this initiative was to gather data and to show data and raise awareness of AKI. This was one of the first studies published, and is a systematic review and meta-analysis. Here they compare the incidence of AKI in different settings and compare low and low-middle income countries versus high-income countries. As you could see, in Latin America, the AKI incidence in the ICU is between 7 to 12%, as compared of 18 to 20% in the ICUs in high-income countries. Death rate is higher, 43% in Latin America, as compared of 14 to 46% in high-income countries. And one thing important, and I want to highlight, is that end-stage kidney disease is an important adverse outcome, as the previous study also has shown. It's between 7 to 18% in low and low-middle income countries, higher than the previous study, and could be as high as 23% in high-income countries. The second study of the 0 by 25 initiative was this 0 by 25 global snapshot study, that was a multinational cross-sectional study. For 1 week, all around the world, the initiative collected data about AKI episodes. This study shows that the incidence of AKI in the ICU is higher in high-income countries, and is similar in countries who have upper middle income and low-middle income, between 27% to 29%. Finally, etiological risk factors are also important, things that we need to look at, because in most of the cases, they are easily identifiable and also preventable. The 5 most common causes of AKI and risk factors were dehydration, hypotension, infection, community-acquired, sepsis, and the use of nephrotoxic agents. So, since we don't have any specific therapy for AKI in the ICU or in the community, early detection is essential. And I'm going to show you 2 strategies to early identify AKI and start therapeutic maneuvers. The first one is the Nephrology Rapid Response Team that was developed by Claudio Ronco and his team. They proposed an algorithm, and they call this algorithm the Fantastic Four. So you have a clinical scenario where you have to review signs, symptoms, circumstances, and risk factors for AKI. Then you have to review past medical history. So you will assess level of susceptibility and intensity of exposure. Then you will need to perform a physical examination focusing on hemodynamic instability, volume depletion, fluid overload, and signs and source of infection. And finally, we use lab test results and especially biomarkers to stratify each individual risk for AKI. Here you could see every aspect of this Fantastic Four concept. I'm going to show you how to use in the next slide. One thing that is really important is that this approach is focused in detecting AKI at a subclinical level with the use of biomarkers, and it encompasses with this recent study and these recent recommendations proposed by the AKI group. And they propose to further classify or having different phenotypes of AKI with the use of biomarkers. If you have a patient with a biomarker positive, either NGAL, IL-18, KIM1, cystatin C, etc., but you don't have any increase in serum creatinine level or decrease in urine output, you will be classified as AKI stage 1S, or what we used to know as subclinical AKI. If you have a biomarker negative but increase in serum creatinine level or decreased urine output, you will further be classified as AKI stage 1A. And if you have both things, that means biomarker positive and an increase in serum creatinine or decrease in urine output, you will be in AKI stage 1B, with a higher risk of complications, higher risk of progression into chronic kidney disease, and having more adverse outcomes. That is why it's extremely important to identify AKI at early stages. So how we should use this nephrology rapid response team proposal. So when we first see a patient in the ICU, we stratify each individual risk, and they propose to use biomarkers. They propose to use, in this case, the NephroCheck, and they could stratify patients into low, high, or moderate risk. Patients with low risk, that means that if they have a NephroCheck equal or lower than 0.3, will be to continuously be reassessed in order to identify risk of AKI, or each individual risk has a change. If the risk is moderate, that means the NephroCheck value is between 0.3 and lower than 2, you could further assess other biomarkers or follow up more closely with serum creatinine, looking at each individual's urine output, and repeat all Fantastic Four approach each 24 hours or between 48 hours. However, if you have a NephroCheck with a value equal or higher than 2, that means that your patient is at high risk of developing AKI. That should you prompt an electronic alert, and that should activate your nephrology rapid response team. What you should do once you identify the patient that has developed AKI who was at high risk? Well, you first have to stratify AKI stage into subclinical AKI, clinical AKI, KDIGO stage 1 or KDIGO stage 2, 3, or AKI plus renal replacement therapy. Then it's important to use a standardized bundle of care, so you will avoid AKI evolution and try to find AKI cause. That should be done in the next 12 to 48 hours. And finally, you should follow up your patient at hospital discharge. Depending on the stage of AKI, you will follow your patient after 3 months, after a month, between 2 weeks or 1 week, depending of KDIGO stage, and finally, in 3 days, if the patient require renal replacement therapy. And this approach should be a multidisciplinary approach where nephrologists, surgeons, and critical care physicians should be involved. The 0 by 25 uses a similar approach and similar concept, even though this was developed for community-acquired AKI, could be adapted, and we have adapted at our institution to be used in patients who are at ICUs or in critical care settings. So they use the concept of the 5 R's. That means you have to assess each individual risk with toolkits. In this case, we use a risk score with active surveillance of patients. Early recognition using clinical tools and point of care testing, which is extremely important in low and low middle income countries. Rapid response with a bundle of care that is protocolized, and also with the help of telemedicine in settings with low resources. That allows for us to intervene early, since the window for early intervention in AKI is really small. Then the 4R is renal support, with the implementation of peritoneal dialysis in low and low middle income countries, telemedicine coordination, and transfer to regional centers in cases of critical cases who could not be resolved in not urban areas. And finally, rehabilitation, similar to what was proposed of the nephrology rapid response team, with a follow-up visit at a local level. We usually do that at 1 month, 3 months, and finally the final visit at 6 months after AKI episode, with the using of point of care tests and guidance via telemedicine. This was the protocol. I'm going to want to show you the risk score. We use using signs and symptoms of patients, and we have a maximum of 17 points. Patients with low risk were those who have 2 or less points. Patients at intermediate risk were those who have 3 to 5 points, and patients at high risk will have 6 or more points. We have, as I previously mentioned, a bundle of care with specific protocols for using fluid resuscitation, 1 protocol for sepsis, 1 protocol for early renal replacement therapy initiation guided by telemedicine, and the main protocol, who was the STOP AKI protocol, who focused on identifying and screening for sepsis, avoiding toxins, optimizing blood pressure, and preventing harm. Quite similar concept of the nephrology rapid response team. Once again, this was developed for community-acquired AKI, but could be adapted for ICU setting, especially in low and low middle income countries. Well, as I showed you previously, volume depletion, hypotension are important causes of AKI in the ICU. So it's important to know which solution we should choose and how to administer solutions in the AKI in the ICU. And since there's a lot of studies in the past 10 years and a lot of discussion about this, I'm going to show you some interesting data. So the first set of studies that I'm going to show you is about if you should use colloids versus crystalloids. And a few years ago, these were these 2 important trials, SUCCESS and CHESS trials, that compare colloids versus crystalloids in terms of adverse kidney outcomes. They have different design, different patients, different settings, and difference in the career solution each study used. However, both studies show that the use of colloids increase the use of renal replacement therapies in patients who receive colloid as compared to crystalloids, and also increase the risk of death by day 90. However, subsequent study, who was the crystal study, who was a randomized trial, an open label and pragmatic trial that was done mostly in ICUs in Europe, North Africa, and Canada, compared the use of colloids versus crystalloid, different types of colloids. They use gelatins, dextrans, and crystalloids, they use isotonic, hypertonic saline, or more balanced solutions. And the primary outcome in this study was death by 28 days, and secondary outcomes were the 90-day mortality, days alive and not receiving renal replacement therapy, mechanical ventilation, and vasopressor therapy. In terms of the primary outcome, they didn't find any difference, and by day 90, that was one of the secondary outcomes, mortality was lower in patients who receive colloids. And that could be interpreted that maybe the effectiveness of resuscitation could have an impact in the long term, but that's something we will not know. But that's some interesting finding in this study. Again, they couldn't find any difference between different groups, hypovolemic shock from other causes, sepsis, or trauma. The other discussion that has been very intense in the recent years is if we should use a balanced solution or we should use isotonic solution as what we have been calling abnormal saline. Here I'm showing different composition of the different solutions and as compared to plasma. As you could see, chloride content in plasma is 100 and saline has 154. Ringer lactate and other balanced crystalloid has a closer chloride content as plasma. So this in experimental models has shown that could increase the risk of AKI. This is an experimental model of sepsis, and in rats, where authors provoke sepsis in these animals, and then resuscitate with different solutions with different chloride content, medium content or high content of chloride. You could see here that the resuscitation was very successful in both groups of animals. However, as the chloride content of the solution you use, the pH goes down, and this has an impact on pro-inflammatory cytokines and increased values of IL-6, IL-10, and TNF, and that was translated into a development of AKI. In human studies, was one of the first that analyzed the effect or the impact of high chloride content of solutions in renal outcomes. It was published in JAMA a few years ago, and here what they have done was that during a control period, patients receive standard IV fluids in a 6-month period. They could use any type of high chloride content solutions that will be 0.9 saline, normal saline, 4% succinate gelatin solution, or 4% albumin solution. After this period of time, all physicians were restricted to use just only low chloride content solutions, that being Harman, a balanced solution that was plasmalide, or chloride per 20% albumin. Here you could see the chloride content of the different solutions that were used in this study. And in terms of renal adverse outcome, patients who were in the control period where high chloride content solutions were used have an increased risk of AKI rifle classes I and F. Next, you have this study, the split randomized clinical trial. This was a study done in the ICU where patients were assigned to either a balanced solution and compared to normal saline. The primary outcome was the proportion of patients with AKI, and main secondary outcomes were incidence of renal replacement therapy use or in-hospital mortality. Here, there were no difference in AKI, also no difference in mortality or renal replacement therapy requirements. However, one of the things I want to highlight you is that the total amount of solution that was used was no more than 2 liters in both arms, in both group of patients. That's important to remember since solutions are medications and they have like every medication, indications, contraindications, adverse outcomes, and toxic doses of each solutions. More recent trial is the BASIC trial, was a randomized clinical trial. This study have a factorial 2x2 randomized study, and they randomized 1:1:1 ratio to each fluid solution, a balanced solution versus sodium chloride normal saline. And also they randomized to a high versus low rate of administration. It was done in 75 ICUs in Brazil, and data was collected from 2017 to 2020. The population they studied were patients who were admitted to the ICU with need of fluid resuscitation. They find one sign of hypoperfusion and one sign of fluid response. They were not expected to be discharged the day after they were admitted, and they should have at least one risk factor for AKI that was age higher than 60 years, hypotension, sepsis, mechanical ventilation, oliguria, raised serum creatinine level, cirrhosis of acute liver failure. Here you could see the number of patients who were randomized to receive normal saline and the number of patients who received balanced solution, and they were further divided into patients who receive a rapid infusion rate versus those who receive a slower infusion rate. Here you have select the baseline characteristic of the patients. No difference between groups, and no difference also in the amount of fluids they received prior to be enrolled in the study, or the amount of solution, if either it was normal saline versus it was a balanced solutions. In terms of the fluid type, the authors didn't find any difference in terms of 90-day mortality. Also, no difference between renal replacement therapy requirement or development of AKI stage 2 or higher using KDIGO guidelines definition. In terms of fluid rate, again, no difference between 90-day mortality or adverse kidney outcomes. That means no difference in renal replacement therapy requirement, and no difference in development of AKI KDIGO stage 2 or higher. Finally, this study also compared the use of balanced solution versus normal saline. This is the SMART study, but this time they assess biomarkers. They use NGAL for assessing kidney injury, and as compared with the previous studies that I have shown you, in this study, authors found an increase levels of NGAL in patients who were randomized to receive saline. So maybe it could be that a signal for kidney injury and subclinical AKI. Well, how you should use any type of fluid once you choose either a balanced solution or a normal saline, or colloid versus crystalloid. It's important to have a protocolized approach. As you could see, again, the therapeutic window for fluid use is very short, and you could easily go from being hypovolemic to be hypervolemic. So here you could use the benefit and harm ratio. So my first choice would be buffer crystalloids, but in some cases I could use isotonic saline, especially in patients who are hypochloremic. Also, low chloride content albumin could be used, and the last choices would be to use colloids. You should use a serial assessment using clinical signs of hypoperfusion, but also technology is extremely helpful in this situation. POCs, bioimpedance analysis are extremely useful in order to evaluate fluid response, the assessment of fluid responsiveness in patients at risk or with AKI. So I like very much this concept of the 4 phases of intravenous fluid therapy that was published a few years in the British Journal of Anesthesia, and they use the mnemotechnic ROSE. So they have 4 stages that would be rescue, optimization, stabilization, and de-escalation. So each of these stages have a specific goals and how to use fluid therapy. In the first stage, your goal will be to correct shock, and you should use rapid boluses. In the stage of optimization, you need to optimize and maintain tissue perfusion. That you will need to titrate fluid infusion conservatively using small fluid challenges. In the third stage, the stabilization stage, you should aim for zero or negative fluid balance. Here, patients should be have just minimal maintenance infusion, and only if their oral intake is inadequate. And finally, in the de-escalation, you need to mobilize fluid that has accumulated during the other 3 stages. Patients should just be receiving oral intake if feasible, and avoid unnecessary IV fluids. So these are the types of maneuvers that you will do with your IV fluids in each of the stages. In the first stage, you should use fluid volumes, at least 5 mL over a maximum of 15 minutes. In the second stage, you should use fluid challenges, small amounts of fluid over 5 to 10 minutes, 100 to 200 mLs with reassessment in order to optimize the tissue perfusion. In the third stage, you should use fluid infusion. That means continuous delivery of IV fluids just to maintain homeostasis, replace losses, or prevent organ injury. And finally, in maintenance, you could administer fluid just in the case where oral is not a feasible way to administer fluids, and in patients who cannot meet their needs. And this is what they propose, a maximum of 1 to 2 mL per kilogram per hour of IV fluids. So what will be the do and do nots in fluid management in AKI? You should use IV fluids for intravascular hypovolemia, and never use to treat oliguria without hypovolemia. In terms of type of fluids, you should choose crystalloids, not colloids. And since the recent data, it could be equally to use balance versus normal saline type of solutions. In terms of volume, always use small aliquots of boluses and never use high volumes of solutions. In terms of the duration of the therapy, you should use IV fluids until hypovolemia is corrected and never until AKI is resolved. What about the use of diuretics? This is a common practice in some ICUs to start IV furosemide when the patient is oliguric or when the urine volume is not what the physician is expecting. So there's a study who analyzed if furosemide could modify the course of and the outcomes of AKI. It was a multi-center randomized control trial in adult patients where the authors administered low-dose furosemide, 0.4 milligrams per kilogram as a loading dose, and an infusion rate of 0.05 milligrams per kilogram per hour. The primary outcome in this study was the worsening of AKI, and secondary outcomes were renal replacement requirement, adverse events, and kidney recovery. They didn't found any difference in terms of worsened AKI, cumulative fluid balance, kidney recovery, patients who receive renal replacement therapy, ICU death, or mortality at 90 days. And what they found is more adverse events in patients who were randomized to receive furosemide, especially electrolyte abnormalities. Finally, timing of renal replacement therapy in patients with AKI. Here I'm going to show you this fantastic infographic made by NephJC group, where we could see the most recent studies who assess early versus late initiation of kidney replacement therapy in patients with AKI. All of these are randomized controlled trials, except for Elaine, who was just done in a single center. The rest of the studies are multi-center, multinational studies. The only study from these studies who assess early versus late initiation of kidney replacement therapy who show any difference in mortality with a lower mortality at 90 days were in patients who receive early renal replacement therapy was the Lane study. However, this study was again done in a single center, was a small sample size, and most of the patients were surgical patients. What we have, or these studies have shown, is that early start of renal replacement therapy in patients with AKI was associated with increased risk of complications related to the renal replacement therapy, like electrolyte abnormalities like hypokalemia, hypophosphatemia, increased risk of infections, increased dependence of renal replacement therapy at day 90, etc. So what we could see from these studies is that we should individualize the initiation of renal replacement therapy in each of our patients. We have also a meta-analysis that was published last year that include all of the studies that I have previously showed you. Again, this meta-analysis didn't show any difference between early or delayed renal replacement therapy start in terms of 20 and 90-day mortality. Either no difference in renal replacement therapy dependence among survivors at 28 and 90 days, but they found an increased risk of adverse outcomes, hypotension, infection, arrhythmias, and bleeding events. So in conclusions, AKI is prevalent in critically ill patients in the ICU. Most common etiologies of AKI are fluid volume deficit and kidney hypoperfusion, and inflammatory states associated with sepsis, and the use of nephrotoxic drugs. Careful evaluation of patients' clinical situation, along with the use of risk scores, biomarkers, and point-of-care tests should allow for early identification, as I have shown you, two different models and two different proposals, as were the Nephrology Rapid Response Team and the 0/25 initiative. A protocol-based approach is extremely important. Either you could use the approach of Nephrology Rapid Response Team with the use of biomarkers, or the concept of 5 R's used by the 0/25. These proposals show that they could reduce AKI development, AKI progression, patient requiring renal replacement therapy, and mortality. In terms of fluid administration, these should be individualized and should consider nature of acute illness, trajectories, risks, and benefits of fluids. Remember that fluids are drugs, and their use should be individualized. Existing data support the preferential use of buffer solutions in patients who do not have hypochloremia. About furosemide, the use in early AKI did not reduce the incidence of AKI worsening, neither reduce the use of renal replacement therapy, neither reduce mortality, volume overload, AKI duration, or did not improve renal recovery. In terms of renal replacement therapy, early was not associated with a survival benefit and could lead to an unnecessary renal replacement therapy exposure in most of the patients, with adverse outcomes and adverse impact on nutrition, electrolytes, infection, and hypotension. Delay initiation might be safe in the absence of life-threatening conditions. And with that, I will end my presentation. I want to thank everyone for listening to me. Back to you, Rick.
Thank you, Dr. Clary Del Granado, for that interesting look at AKI, where the presentation, diagnosis, and treatment can be so complex and varied among affected patients. Next, we'll hear from Dr. Begos, followed by a Q&A session with Dr. Clary Del Granado. Dennis will talk about NOVA's role in nephrology, some recent clinical studies, and our broad portfolio of whole blood diagnostic products with tests that can aid in fighting kidney disease. Dennis?
Thank you, Rick, and thanks, Dr. Clary, for really an excellent presentation on diagnosis and management of acute kidney injury in ICU patients. I think we're all really fortunate to have Dr. Clary speak to this, as he really is an international expert in this area, and it was a fantastic presentation. Today, I'd like to just expand upon his presentation a little bit and perhaps talk more about acute kidney injury outside the ICU, and also how point-of-care testing can help manage and diagnose this group of patients. So as Dr. Clary noted so well in his talk, we know that acute kidney injury is a significant problem in patients who are critically ill and in the ICU, but it's not just a problem for critically ill patients. There are significant issues with acute kidney injury outside the ICU, and in fact, even outside the hospital. And those include patients with contrast-induced nephrotoxicity who are getting radiologic exams, or cardiac catheterizations, for example, and who get a contrast load. Many of those patients go home the same day after those procedures. There are patients who are on nephrotoxic medications, again, both in and out of the hospital. Patients with comorbidities such as diabetes and hypertension are at increased risk for both acute kidney injury and chronic kidney disease. And patients with chronic kidney disease also have an increased incidence of AKI. As we learn more about COVID, we also know that COVID is a significant risk factor for AKI in patients who are hospitalized with COVID. One of the issues with AKI is that it's often recognized late. So early detection, just like with any disease, is the key to help minimize morbidity and decrease complications moving forward in the future. In treating AKI, really the goals are fairly straightforward. We want to prevent or minimize any further damage to the kidneys, and by to do this, the primary goal is to treat the underlying cause, whether it's sepsis, hypotension, nephrotoxic medications, et cetera, is to identify and treat the underlying cause rapidly. We want to preserve kidney function, reverse any kidney dysfunction, and also provide supportive care as needed, including peritoneal dialysis or CRRT as needed. So let's shift gears slightly and talk about AKI in patients with COVID-19. And COVID-19 obviously is on the top of everybody's minds these days, but it can also serve as an example for AKI in other groups of patients. And if you look at the graphic on the right, it shows the kind of the multifactorial nature of acute kidney injury in these patient groups. If you start around the 11 o'clock position, COVID generally starts as a lung injury. Once a patient's hospitalized, they're often placed on nephrotoxic medications. COVID can also cause cardiac issues such as decreased cardiac output or congestive heart failure, and this can affect renal perfusion. We also know that COVID can directly infect the kidneys, and so this can also play a role in acute kidney injury in this patient group. There are various genetic factors that predispose certain patient groups to acute kidney injury, not just with COVID, but with many other diseases. COVID can also cause a cytokine storm, which can cause a septic response and also lead to acute kidney injury, or certainly contribute to that. COVID has cellular effects causing mitochondrial dysfunction, which again can also lead to kidney dysfunction. Many patients have rhabdomyolysis, and there's also some evidence that there's primary endothelial damage or microclots, which can also affect renal perfusion and lead to kidney injury in this patient group. So there's really a whole host of reasons why a patient with COVID can develop AKI. We know that in hospitalized patients, about 30 to 40% of COVID patients will develop AKI. Patients who are in the ICU, it can be as high as 80%. And those patients, up to 40% of those patients may require renal replacement therapy. So AKI is a significant problem in COVID-19. In addition, AKI is a marker for a significant increase in mortality in patients with COVID-19. This is a study from almost 10,000 hospitalized patients in New York State, and roughly 40% of them developed AKI during the course of their illness. If you can see on the slide on the left, patients who didn't develop AKI during their illness had a mortality rate of about 5%. Patients with AKI who did not require renal replacement therapy had a mortality rate of around 40%, and the most severe group, patients who did require renal replacement therapy, had a mortality rate of almost 80%. So AKI may be a marker for more severe disease, but it also likely plays a primary role in outcomes in this patient group. And one simple way of evaluating and monitoring these patients is with point-of-care testing. So the image on the right is that of a Nova Prime Plus. It's a blood gas analyzer, but it also does a lot more, and it can be very useful in identifying and managing patients with acute kidney injury. First off, it provides fast results, so it's around a 60-second turnaround time to get a result back, whereas oftentimes hospital labs can take an hour or two to result things such as creatinine or electrolytes. And with a point-of-care device, there's likely less pre-analytic error in that the blood doesn't have to be transported to the lab and potentially sit in the lab for an unidentified or an unknown period of time prior to getting run by the analyzer. The Prime Plus uses an enzymatic method for determining creatinine, which is the one recommended by nephrologists and laboratorians. Many hospital labs still use a Jaffe or colorimetric method, which may not be as accurate as an enzymatic method. The Prime Plus also allows for near real-time monitoring of electrolytes and a fairly comprehensive metabolic panel, including standard electrolytes such as sodium, potassium, chloride, but also it will measure ionized magnesium and ionized calcium and bicarb. So these patients, particularly patients who are on CRRT, can be monitored again in just about real time for their electrolytes and coagulation status. It will measure pH as part of a blood gas panel. It can calculate plasma volume based on the hemoglobin and hematocrit, and it can do all that with only about 90 microliters of blood. So anemia from phlebotomy is likely going to be less of a problem if a device such like this is being used. And one of the issues with acute kidney injury is the unknown prognosis of it. So back in 2017, this was a consensus paper that was published by the Acute Disease Quality Initiative, which is an international consensus group who discussed the overall prognosis and management of patients with acute kidney injury. And you can see the graphic on the right talks about different stages of acute kidney injury from most severe to less severe on the left. If acute kidney injury lasts longer than 7 days, the nomenclature changes to acute kidney disease, and acute kidney disease can last up to 90 days, and if kidney disease persists after 90 days, then we consider it chronic kidney disease. And you can see the progression from left to right, from acute kidney injury to acute kidney disease to potential chronic kidney disease. One of the issues is we don't really know, these don't map one-to-one, so we don't know the number of patients who progress from acute kidney injury to acute kidney disease and subsequent chronic kidney disease, because follow-up isn't necessarily complete or thorough in all these patients. And you can see here, this is again is from the same paper. Although follow-up isn't particularly regimented or quantified, we know that patients with more severe disease are going to need earlier and more frequent follow-up and likely need follow-up with a nephrologist. But if the authors point out that if every patient required follow-up with a nephrologist, it would overwhelm the system. There's simply just not enough resources to manage these patients. So it's somewhat of a judgment call by providers as to how aggressive, how frequently, how early these patients need to be monitored. And a quote from the paper is interesting. It shows that data from Medicare claims and the Veterans Affairs database indicate that only 50 to 69% of patients have a serum creatinine level measured within 3 months of an episode of AKI. So you would think at the very least these patients should have a follow-up creatinine at some point in the first 3 months in follow-up, but that's not necessarily the case. And in another paper, again talking about follow-up of acute kidney injury, this was a paper out of Belgium in 2018, and they highlight the fact that, again quoting from the authors, even if post-discharge kidney function returns to normal, any hospital admission with AKI is associated with increased risk of renal progression that may persist for up to 10 years. There's no clear recommendation on the duration that AKI survivors should be monitored after the AKI episode for evaluation of CKD development. Sub-guidelines suggest a follow-up for 2 to 3 years, even if there's a return to baseline function. So follow-up of these patients in the outpatient setting is critical, but the guidelines are unclear, and part of the deficiency in having these patients followed up the way they should be could be the deficiency in being able to measure creatinine in some of these patients. They may be in a remote setting or may not have easy access to a hospital laboratory, or cost may be an issue. So one potential solution to this issue is, again, point of care management. So you can see in the image on the right, Nova Biomedical makes now several handheld analyzers that can measure creatinine and eGFR using just a finger stick of blood. Currently, they are not approved in the U.S. for self-testing, but we hope to have that approval very shortly. They are being used in Europe and being studied in Europe. And this would, I think, present an ideal use for managing AKI patients in the outpatient setting. There's already studies and data that support their use in early detection of contrast-induced nephropathy, so they can be used in patients following a contrast load. They've also been used in outpatient radiology centers to identify patients who may potentially be at risk for AKI following a contrast load. They've been used in renal transplant patients to follow their creatinine following kidney transplant. They're being used in pharmacies to identify patients who are on nephrotoxic medications who may require a dose adjustment, and also to even identify patients who are at risk for chronic kidney disease to try to identify and screen for that in that patient group. There's been some studies looking at these devices in population screening, and as now novel treatments for chronic kidney disease are becoming more readily available, and the financial burden of chronic kidney disease to the healthcare system, I think early identification of patients with either AKI or chronic kidney disease is going to become more and more important and potentially lead to better care of patients with this disease. And then finally, if there's one thing that the COVID pandemic helped bring about is telemedicine, and certainly telenephrology is a burgeoning field at the moment. And again, patients may not necessarily be able to get to see a nephrologist in person, but doing so by a telenephrology method and having the ability to measure creatinine at home and interact with a nephrologist, even if it's by video, is something that could be very valuable in this patient group. So in conclusion, acute kidney injury continues to be a major healthcare concern, both in and out of the hospital. It's known to cause an increase in mortality in hospitalized patients. There's a definite but somewhat undetermined progression to chronic kidney disease in this patient group, and it does increase overall morbidity. I believe that management of acute kidney injury and diagnosis of acute kidney injury is made easier and potentially better by using point-of-care devices. Right now, outpatient follow-up for acute kidney injury patients is not well defined, and again, I think point-of-care testing can play a role in this. And so overall, I think in both inpatient and outpatient settings, point-of-care testing for creatinine, electrolytes, and other variables can really have a major impact in managing patients with this disease. Thank you very much for attending today's webinar. On behalf of Novo Biomedical, we really appreciate your attendance and interest in this topic. If you have any questions, remember to submit them via the link on your screen. If you're watching this on demand or if your question isn't answered, please feel free to email me at my email address on the screen. Now I'll turn it back over to Rick for the Q&A session. Thanks again.
Thank you, Dennis. Now, before we begin the question and answer session, I want to remind you to submit questions for Dr. Clare Del Granado and Dr. Begos using the Q&A window on your screen. Also, as a reminder, your continuing education certificates will be emailed once you complete the post-webinar survey. A link will be sent to you about an hour after we conclude this session. Now, on to our questions. Is there a role for point-of-care testing in patients with AKI in the hospital? What are the advantages and disadvantages of point-of-care testing for critically ill patients?
That's an interesting question, and of course, there's an opportunity of use point-of-care tests in the hospital setting, especially in low and low-middle income countries where central labs are not always available, and you could have in 30 seconds serum creatinine value that could provide you important information to early identify patients of AKI.
Okay, thank you for that answer. Next, What is the recommended follow-up for these patients after they leave the hospital? And what is the recurrence rate?
That's an important question too. And as I show you, different groups propose different time frames for follow-up patients. You should always follow up your patient after he or she develop a AKI. In the 0/25 protocol, follow-up visits were done at 1 month, at 3 months, and 6 months. In the nephrology rapid response team approach, it depends on the AKI stage. If it was subclinical AKI, or what now AKI will call stage 1S, they propose to see the patient in 3 months. If it's a patient who developed AKI stage 1 or 2 or 3, they should be seen within 1 month. And if patient has AKI stage 3 and require renal replacement therapy, these patients should be seen within 3 years of hospital discharge.
Okay, thank you. Next, once a patient develops AKI with markers for kidney damage, does their kidney function permanently deteriorate, or can they regain or regenerate lost nephrons?
That's also an interesting question. And the patients, there's a concept of a continuum in kidney disease. So you have three stages. That means you could be having AKI, then you could develop acute kidney disease, and then you could develop chronic kidney disease, or you could progress to chronic kidney disease. Most of the patients, between 75% to 80% of the patients, once they have an acute kidney injury episode, will recover completely. So they will not progress to acute kidney disease. Patients who depending on the damage they will suffer in their kidneys, if they have stage 2 to 3, they have an increased risk of not recovering their function, and they could develop acute kidney disease. That is when after 7 days they don't return to their baseline serum creatinine, and the eGFR is lower than 60 mLs per minute, 1.73 square meters. Or they have biomarkers of kidney damage that could be leukocyturia, hematuria, or proteinuria in the urine. And if those patients who progress from AKI to acute kidney disease, they are at higher risk to progress to chronic kidney disease. So it depends on the magnitude of the damage in each individual.
Great, thanks for that answer. Next, there are many novel markers of kidney damage currently being evaluated. Which ones do you think are most important?
In terms of biomarkers, as the question was framed, there are a lot of biomarkers that could be used for identifying structural damage. So like NGAL, IL-18, KIN1, the NephroCheck, etc. One of the issues of the different biomarkers is that we don't have we have different cutoffs in different settings. For example, ischemic damage, sepsis, after cardiovascular surgery, etc. But one of the most promising biomarkers we have is the NephroCheck. And as I show you, this nephrology rapid response team assessment of early identification of patients in high risk of AKI and with AKI uses the NephroCheck. So that would be one of the one of the biomarkers that could be used for assessment patients at risk or with AKI and early identification.
Okay, thank you for that. Now, with new markers for AKI, is creatinine still relevant?
Yeah, I think serum creatinine is and will still be relevant. And as show you this new set of recommendations from AKI about the use of biomarkers in AKI shows you that. So we will need to use biomarkers, serum creatinine, to subphenotype patients with AKI. So a patient with a biomarker positive but who has no increase in serum creatinine will be an early stage of AKI as compared with a patient who has a biomarker positive and an increase in serum creatinine. So the serum creatinine will still have its role in AKI.
Great, thanks. Our next question, if you had a choice between a point-of-care meter using the enzymatic method for measuring creatinine versus a central laboratory analyzer using Jaffe, which one would you choose?
I think that will depend on the setting I'm working. If I'm working in a setting with low resources, with no central lab available, the point of care devices are extremely useful as they show their value in the 0 by 25 initiative. But both are good alternatives to identify AKI. The main thing is that you should focus on early identifications at patients at risk or with AKI, and doesn't using a point of care test or central lab. It will not, from my point of view, make any difference. The difference will make if you recognize AKI at an early stage, or you recognize patients at a higher risk of AKI.
Okay, we have a lot of great questions coming in. Thank you to our audience for that. We have time for one more question. Would AKI outcome be improved with more frequent checks of creatinine and electrolytes?
Okay, that's also an interesting question. And there is some data that a closer monitoring of serum creatinine and also urine output could improve outcomes. There's this interesting study done by John Kellogg and its group in Pittsburgh, where patients, they analyze patients who were closely monitored from serum creatinine levels and urine output, and compared with patients who didn't have either serum creatinine monitoring or urine output monitoring closely in the ICUs, and patients in which serum creatinine levels were closely monitored or urine output was closely monitored have a lower increase of AKI development, lower mortality rate, and lower fluid volume overload, who is also related to an increased risk of mortality. So close monitoring of serum creatinine levels and urine output is extremely important, and that's one of the recommendations that was done by KDIGO guidelines published in 2012.
Okay, thanks to our attendees for those great questions again. Look for a follow-up email with a full list of questions and answers from today's session. Be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you will find a full catalog of on-demand webinar offerings. So that concludes our webinar for today. For Dr. Clare Del Granado and Dr. Bagos, I would like to thank you for attending and wish you a great rest of the day.